Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of the Next Breast Thing,
my daughter and I went on an overnight camping trip in a cave. We lapelled.
I'm not a California native, so I have not experienced that many earthquakes, but this...
I now have a baby cow.
Our topic today is how the breast surgeon's role in neoadjuvant treatment continues to evolve.
Maybe a clip wasn't placed. I mean, we see that on occasion, or the clip has come out, and now what do you...
What about elderly patients and doing aromatase inhibitor?
Maybe not everybody needs surgery. That's a conversation to have with certain tumor types.
It's such an exciting time to be a breast surgeon.
What complications have you guys seen from neoadjuvant?
I think the one that affects us as surgeons is sometimes...
Because a treatment can't be worse than the cure. And I had this recently, actually, in my office.
You get lazy sometimes and say, well, I'm just going to send you to the medical oncologist and they're going to tell you what you need and then you'll come back. We got to do better than that. We've got to know.
This is Carla,
Ellie,
Michael,
Susie,
Sitcha,
And Susan. Welcome to the Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care
to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
Our topic today is how the breast surgeon's role in neoadjuvant treatment continues to evolve. But before we get started, let's begin with some personal and professional updates. Susie, what's new with you?
I am so excited to share with you all. I went to Belize with my daughter to this place called Caves Branch, and we got to do so many outdoor activities. And they have things for people who are more risk averse, like floating on a tube through a cave, and these beautiful places to stay and great things to eat. But my daughter and I went on an overnight camping trip in a cave. We rappelled 250 feet, saw Maya ruins, and it was just us and two guides. Unbelievable. It was so amazing. But Ellie, I have been thinking so much about you with the recent earthquakes in California, and things keep happening around your area. Are you doing okay?
Yeah. I'm doing okay. I'm not a California native, so I have not experienced that many earthquakes. The walls were shaking. I've seen a patient, actually. We all got alerts on our phone, and then it just started. Everything was fine, at least where I am, so thank you so much for asking. Otherwise, just some updates about me. I actually just got back from Coachella last weekend. I saw Lady Gaga for the first time among many other artists, but she's one of my absolute favorites, and she did not disappoint. She was incredible. She brought all the stops, and it was one of the coolest experiences. So if you all ever get a chance to see her perform, it's a real treat. It was really like Broadway show, but in an outdoor theater. So it was incredible. Michael, how are you doing? Congratulations.
Well, thank you very much. I have two updates. Update number one is I found out that even in old Vegas, you could lose lots of money. And so my retirement plan is now out the window. So I'm moving on to my second retirement plan, which is my cow-calf operation. I now have a baby cow. We were having all these storms, and I went to make sure that the cow was still there, couldn't find her, and she was off by herself in the woods having the baby. And it was like a scene from Bambi. I mean, it was real wobbly legs, and it's a It's a little cute. Baby's little, look at the chat on that, and you can see a picture of 23's baby. So we're really excited. I'm excited about naming 23's baby, and we'll see what the contest shows on that. Sitcha, how old is your daughter, and how old does your daughter think she is?
She just turned 2 and she thinks she's 7 now. You all are so exciting. Oh my God, Belize and Lady Gaga and a baby cow. I have no updates to compare. My kids both have a cold. Flu season is not over. So let's move on to our topic today, how the breast surgeon's role in neoadjuvant treatment continues to evolve. Are we the gatekeepers? Is the breast surgeon the gatekeeper? Are patients usually seeing the medical teams first? Where are your referrals coming from? I think every hospital system is different.
At my current system and how it was in my fellowship, I see the patient first. So I see them first, and then I opt to get medical oncology involved, and then we usually make a joint decision together in addition to the patient if we're going to do neoadjuvant chemotherapy or not. That's at least how my clinic works. What about you guys?
I think around the country, it is generally the surgeon that sees that patient first. It's a rare time that I'll see somebody referred to me from a medical oncologist. The patient gets a diagnosis and is referred to a surgeon. Consequently, the decision for neoadjuvant therapy probably falls mostly on the surgeon. And if the surgeon is not thinking in regards of neoadjuvant therapy and its benefits, you may miss out on a real opportunity for the patient to either get the appropriate treatment or salvage treatment or whatever that may be. We do function in a multidisciplinary group, but there's nothing that says that we just can't take somebody to the operating room. If we see them and we book them and we take them, that's on us. So I think our discussion today is going to be the challenge to surgeons to be thinking about neoadjuvant therapy.
Yeah, I totally agree, Michael. At our institution, we as surgeons most often will see the patients first. And it's often us who have to say, hey, in this type of cancer, I think you're going to need to have chemotherapy first. And it really blows patients away, at least some of ours, because they're like, well, I'm in a surgeon's office and I just want to get surgery done. And having to explain what are the benefits of neoadjuvant chemo. How do you all explain to your patients like, hey, this is why we have to flip it around?
So our system is very similar. It's generally surgery first as well. But I'm also in an academic setting, and I see a lot of people come through starting in the community setting. And that's part of why I put the question out there, because I do see a lot of referrals going straight to a medical oncologist and then getting the surgeon involved. In fact, I'm still sometimes seeing patients, again, not coming through our system initially, but I'm still seeing patients who have already initiated chemotherapy. And yet I'm chasing down things that needed to be biopsied still in order to do breast conservation safely and try to make those decisions as an afterthought, trying to see if there were clips placed in the axilla, sometimes even not in the breast. We have a huge international population, and sometimes I'm seeing patients diagnosed in other countries and come through without clips in the breast even to mark their cancer. It puts me at a little bit of a disadvantage picking up after chemo's already started. And sometimes even after patients have been effectively downstaged, yet didn't have any of these happen. You guys don't have that happen at your institutes?
We'll have it happen. Again, we're in a little bit different situation, and that really puts us at a disadvantage. And I think it's going to be incumbent on us to inform our medical oncologists that it's kind of not okay to start therapy without us having seen the patient first. Examining the patient, seeing what size we're dealing with. Are we happy that all the imaging is clear? Have we evaluated the axilla? What are our goals for this patient? It's hard to do that sometimes, but there's a gentle way of talking to the medical oncologist and sort of informing them that, hey, you really kind of put me in a bind, kind of like you were describing, Sitcha, that it's hard for me to retrieve, and maybe a clip wasn't placed. I mean, we see that on occasion, or the clip has come out, and now what do? I think it's going to have to take a lot of communication, not just with the patients, but with the medical oncologist when you see that happen to you.
Yeah, absolutely. By and large, just as everyone mentioned, it is a multidisciplinary decision, and it's such a complex decision making, and the needle keeps moving on who is appropriate for neoadjuvant therapy. So how do you guys go about making those decisions amongst your multidisciplinary team?
I would say for us, in general, if someone's HER2/neu positive, unless it's really small, and even when it's really small, they really need to have a face-to-face discussion just so that they're learning about that ahead of time. And I think we see things with triple negative, but I think how we generally approach it is if it's seeing surgery first, as we present at the Multidisciplinary Breast Conference, and we always offer our patients, do you want to also see medical oncology before surgery? And they may not offer anything at that time. But even if it's to discuss oncotype or something, they can do that. And likewise, I'm fortunate. Our medical oncologists really want them to see surgery early on just to start that discussion. And I think that's really great. And I especially agree that clip in the axilla, oh my goodness, our radiologists are all grateful when they can do that when it's bigger. And the patients, it's easier on them.
I've got a little perspective of 30 years of watching how neoadjuvant has changed. It used to be that we would say, well, we're going to convert a mastectomy into a partial mastectomy. And when that didn't benefit us, we would just sort of give up on it. And that has really changed now. There's survival data on neoadjuvant therapy. So the surgeon really needs to be aware of what's going on. Susan, she's not with us today, but has said that 50% of her patients are on some form of neoadjuvant therapy. So it's not just for the HER2 positives and the triple negatives anymore. There are trials going on for mass size reduction, or maybe there could even be survival benefit in our hormone receptor positive patients. So I think that should be your first thought is, am I up to date? Do I know what's going on? Do I know what studies are available in my institution or around? Do I know what the best course for this patient is? And then have that discussion with medical oncology. You get lazy sometimes and say, well, I'm just going to send you to the medical oncologist and they're going to tell you what you need and then you'll come back. We got to do better than that. We've got to know what the data is. We've got to know what the treatment plans are. We've basically got to sell that to the patient from the beginning, and we've got to do it with some area of authority and knowledge of what's going on.
I think that's so important when there is a survival benefit. What about elderly patients and doing aromatase inhibitor?
Maybe not everybody needs surgery. That's a conversation to have with certain tumor types. Can you put somebody on a luminal A breast cancer on endocrine therapy that are high risk and monitor them that way? Just because they're seeing a surgeon doesn't mean they have to have surgery. And that is a course of action that we've taken quite a bit. Now, you've got to follow that patient, and if it doesn't respond or it quits responding, and maybe you change therapies a little bit, maybe surgery is going to be in the books for them. And you say, well, maybe I've lost some time because now they're 3 years older than when they first came in at 92. That is something that you ought to have in your quiver to shoot that arrow at somebody and just say, not everybody needs surgery. We're going to treat this. We're going to treat you not only locally, but systemically, and we're going to monitor it closely. And then if it doesn't respond, then maybe surgery is something that we need to do.
I agree, and we employ that approach commonly. However, I also think the kind of surgery we offer is very well tolerated in general. Even in our elderly population, there's some lumpectomies that could easily be done under straight local. I wouldn't discount the importance of getting the cancer out. That's the most effective way of curing people. But you're right, it probably doesn't make a difference overall in certain populations. And we should always be evaluating not just when to do surgery, but also if to do surgery. And I agree with a lot of what you said, Michael. Before that, I was actually going to pick on you first for your vast experience, vast expertise in the topic. Think about just the last 5 to 7 years. I think we probably all remember exactly where we were when Keynote 522 came out, or when CREATE-X was discussed, or the Catherine trials, or APT, even 1071. These trials have just made such a profound difference in just a short period of time. But I can't even imagine, just looking at it from a 30-year wide span, how much change you've seen and how the surgeons played a role in that.
Yeah, for so long, survival really wasn't the issue. It was really more about de-escalation. And if I can take this thing out and rearrange the breast tissue and it's cosmetically okay, then let's just roll. And tumor subtyping has really opened things up for us. Things that are hormone positive may not be a luminal breast cancer, and maybe they would benefit from treating them more like they're a basal. And in the survival bit, I keep going back to that, but that's been the sea change for us, because we'd always tell a patient, hey, look, I can reduce the size of this and we do less surgery, but it's not going to change your overall survival. Now, if you happen to get a path CR, then good for you, but that's not really what we're aiming for. But now that really seems to be a goal, because in a lot of instances, a surrogate for overall survival. And that's what the FDA even shifted when they start to approve things like Perjeta on a neoadjuvant basis. They're able to say, look, we see complete path response as a surrogate for overall survival. We're not going to make this patient be in studies for years and years and years with thousands and thousands of patients. We're going to extrapolate a little bit. That shift happened, I don't know, about 10 or so years ago. And that was the big sea change for me, that we need to be thinking more about this from survival and potential survival versus just de-escalation.
At my institution, a newer thing that our medical oncologists have been doing, especially in cases where it's not triple negative or HER2, but let's say it's like an ER/PR positive patient with very high Ki-67 or even kind of mid-range Ki-67, and they're not in an ideal resectable situation. So they've been sending mammoprints on the core needle biopsy. And then if it's saying they're high risk, then they start them on neoadjuvant chemotherapy. And this is a relatively new thing. They've been doing it over the past 6 months, but we have seen some success with that and some pathologic responses that are higher than like the traditionally quoted numbers. Are any of you doing that in your practices? Is anyone trying to get a little more specific on who are those out of the box people that we're giving neoadjuvant to?
We are. We actually use genomic analysis on the core biopsy on many of our patients. I wouldn't say it's routine, and we still prefer it on a surgical specimen for obvious reasons. More data exists on that, et cetera. But we do employ it a lot, especially in that situation, like you mentioned, where somebody may be considered for a neoadjuvant approach for downstaging, yet what should that neoadjuvant approach be? We certainly don't need to give chemotherapy to somebody with an oncotype of 2. But the other place where we're using that a lot is in clinical trials. And I know a few of you mentioned this already, knowing your institutional preferences as well becomes a really big part of the surgeon's role in addressing who is the appropriate candidate for a neoadjuvant approach, because institutions vary with some of these, and some of that depends on what trials you have available. So I-SPY 2, for example, does a mammoprint ahead of time. We have another clinical trial where we're doing an oncotype pre-assessment or pre-enrollment to determine if the patient's even appropriate for this trial, for example, in a neoadjuvant setting. Here's another example. At my institution, patients with small, even triple negative and HER2 positive breast cancers are often not considered for neoadjuvant approaches, but adjuvant approaches based on the APT trial and based on certain institutional preferences we have, including an ongoing clinical trial. And so, yeah, I mean, those are just a few examples of how your own institutional policies could change your management. And it is so important to be aware of that.
I think it's really neat seeing how breast cancer continues to evolve as evidence-based, but also personal care. And for those patients where we need to step back and pause, and we're getting that experience of saying, hey, maybe this is appropriate to send it ahead of time. And when I think back to these early podcasts of getting to know each other and why we got into this, of how many of us were just driven by the cerebral data that is in this field. It's not just the surgical techniques, but things are evolving and changing, and we're able to engage in that. And it's such an exciting time to be a breast surgeon.
I think that's a good point about the evolution of it. I think I-SPY is great for starting to include tumor subtyping and genomics, because we're still treating patients based on receptor data that's old. All of the trials have been, well, is it HER2 positive? And the most you'd ever get is maybe a FISH or a CISH or a DISH or something to further evaluate that. But I think the next horizon of this is going to be utilizing this tumor subtyping to better identify those patients to treat. And it gets to be perplexing sometimes when the receptor status conflicts with the genomic status a little bit, and then how best to treat that patient. About 15% of hormone receptor positives on certain tests can be basal. What do you do with that? And the data is beginning to suggest treating them like a basal is the most appropriate option. But that falls outside of what most of the studies that we currently are working with show. It is interesting how this evolution is taking us. And I think we tend ourselves to say, yeah, well, this makes sense to me, let's do it. But it takes a bit for the science to sort of catch up with us, I think, sometimes.
Question for the group. What complications have you guys seen from neoadjuvant care? I'm early in my career. I haven't seen that many, but I do remember in fellowship some pretty horrific complications that patients went through occasionally from some of these neoadjuvant medications.
I remember that used to be part of the decision-making back in the day, we used to say, well, maybe you're more optimized for surgery pre-chemo. We used to say that because of some complications of chemo. In general, I think patients overall do very well. Obviously, there are complications and side effects of chemotherapy. I think the one that affects us as surgeons is sometimes the DVTs and then the use of anticoagulation and managing that in the perioperative period. That's one. Obviously, significant weight loss, significant neuropathy can be pretty troublesome for patients and quality of life as well. I don't know, what about everybody else?
They go to chemo teach, and there's really hard outcomes from neoadjuvant chemo. I mean, this is no joke. And we're doing it for a survival benefit, and we're really tailoring not just because something's big, but because it's really going to benefit that patient. But there are going to be people who have really bad complications who it is not the right thing to continue because a treatment can't be worse than the cure. And I had this recently, actually, in my office where she was critically ill after her second dose of chemo that the oncologist is like, we can't go on. And now we're planning for surgery, but having to talk about that when she was like, I knew I should have just had surgery at the beginning because of course she feels that way. And in a sense, maybe she was right. And on the other hand, we were able to look at her scan and say, you know what, you didn't complete everything, but this is where we are. And it was also working, but not at this expense. Michael, what do you see?
Yeah, I think the good news is that most of the time, even with the side effects, they are manageable for surgery. I think the society just put out a resource guide on how long you should wait for surgery before proceeding after certain neoadjuvant therapy. So I think the good news is that for the most part, they're manageable. Like you said, keeping your eye on the prize, though. Why are we doing it? We're not doing it to throw the kitchen sink at them and hope they do well. We've got data that suggests that there's benefit and that if they don't get a complete path response, well, then we're going to reflex to a different medication that has shown even more benefit. So you tend to want to sympathize with them a little bit and say, yeah, I guess we're right. We shouldn't have done it. But I think you really need to impress on why we're doing what we're doing and that we're going to try to manage the side effects. Absolutely. There are times where you just got to stop. Give them a break, do their surgery, and then come back. But that also is a trial that the medical oncologist can use to tailor whether additional chemotherapy is going to be given or how do they back off of that a little bit more. But I think it's to continue to reinforce to the patient, this is why we're doing this. There is a payoff at the end, and most folks make it through with tolerable, no long-term side effects or few.
I have a question for the group. Do y'all get it as excited as I get when I see pathologic complete response on a pathology report? We're all like, hooray.
Yeah.
Yeah. Our pathologist is amazing. And he secure chats us with the pathology as a heads up before he actually puts it into Epic. And if it's a neoadjuvant case, he'll put on the medical oncologist as well as myself. And we're just like the chat back and forth is just like, hooray. And so it should be
chats with like the confetti coming down of congrats, like it does on our phone, but doesn't do on our work computers.
It usually brings tears. I love pathologic complete responses.
Same.
Is there ever going to be a time where we're able to just rebiopsy instead of actually doing a formal surgery? I mean, it doesn't feel good to me now. Like I was thinking if it's me, would I be satisfied with that? But it's really remarkable when it works and there is nothing left. It's really special.
Be careful what you ask for, because I think that's where you may be heading, actually. MD Anderson is doing a trial on triple negatives and HER2 positives, and that's their goal, is does this patient never have to step foot in the operating room? And I think as our targeted therapies get better, we may be operating on what's left. As the path CRs get better, we're going to see more and more of that. So we've got to adjust to that. And that's obviously great news for the patient. If you can avoid surgery and safely do that, then that is absolutely better for the surgeon. Maybe not so much for the breast surgeon, but for the breast patient, there's some real benefit. One of the things that I'd mentioned before about not worrying so much about de-escalation is you were talking about path CR. And I try to divide up path CR in the breast and the axilla, because we'll look at like luminal breast cancers. We'll say, well, only about 10% of those are going to have a complete pathologic response. But in some high risk luminal Bs, that path CR in the axilla may be as high as 35%. So now you're looking at totally changing what surgery you may have to offer that patient, and the morbidity is much, so it may not clear from the breast, but if you're not having to do an axillary dissection or maybe not radiate the axilla, but only having to do a sentinel lymph node biopsy. So even in our luminal Bs that we're a little hesitant to give neoadjuvant therapy to, realize there may be, in a subset, some real benefit in clearing the axilla, even if you don't clear the breast with a path-CR.
Yeah, absolutely. It's really powerful knowledge.
Question for everyone. This was something that I was not prepared for coming out of fellowship. How do you set up checking in with the patient during neoadjuvant chemo? Are you doing it at the middle of it? Are you checking in at the end? How do you all do it in your practice? How often are you checking in with them?
For us in our practice, we typically let medical oncology handle it when they get towards the end of their chemo. We get back together, secure chat, call, and say, hey, when should we do imaging? And when do we plan those next steps? And especially when there's someone who is maybe very committed to a mastectomy, whether or not that's what they need size-wise. There's some people who are just like, I'm done with this, I'm having a mastectomy, so that we can go ahead and get those plastics coordination and get the surgery date on the schedule. But I definitely think that's a multidisciplinary conversation. But I generally don't touch face with them during their chemo time unless there's an issue, for instance, like with their port or something like that.
You know what I've done that works well, and I think it helps encourage the patient, is I'll see them at the midpoint. And I will have evaluated them with ultrasound before we start chemotherapy. And then at the midpoint, you get a pretty good gauge as what's happening here. And that is rewarding for a patient to see that the mass size on this has begun to shrink or the nodes have begun to change. And it also may be a good opportunity to even touch base with the medical oncologist and say, hey, look, I'm looking at this with ultrasound and this thing hadn't changed at all. And do we want to consider pulling the plug on chemo right now, or do we want to consider changing? So that midpoint is good for me. I think what Susie says is absolutely right. You need to see them in enough time to get everything planned for surgery so your hair's not on fire. But that midpoint is a nice checkpoint for me and even the patient to encourage them or to consider our alternatives if this therapy doesn't really be seeming to work like we wanted it to.
Earlier in my practice, I used to see them just at the end and then just try to get everything together really quickly, not realizing the patient hadn't even seen the plastic surgeon, and repeat imaging takes time. And more recently and consistently now, I see the patient at the midway point about 3 months in. Continued conversation about surgical options, getting everything in line, getting all of the order entry for the imaging for post-chemo done. I'll often do the imaging even before. And I agree with Michael. I have seen situations where I'm seeing them and I'm just not happy with the response. And that triggers a discussion with the medical oncologist. And more often than not, we change the route because of that. Not commonly, but that happens. Do you feel that every patient needs imaging before you proceed on to surgery?
I'd say case by case, but I tend to do it on most, especially if I'm looking at the axilla and reevaluating that. I really like to have that for my personal planning on there. So I tend to do it.
Yeah, I do too. I do imaging definitely before.
It also helps with surgical planning as well. All of a sudden, there may be some calcifications pop out that you didn't see behind a mass. MRI is beneficial in that setting to see what's the area of enhancement. So most of the time, unless we're planning on a mastectomy, I want to see what the imaging looks like, not just ultrasound, but even mammography and MRI.
I agree. And I've actually been accused of doing imaging even when I am planning a mastectomy, just to really see what the response was like. You know, I think that teaches us a lot about the cancer as well and the effects of the chemotherapy, but it also helps prepare me for the surgery, even for a mastectomy. Getting back to the structure of how a patient comes in and the role of the surgeon in planning for neoadjuvant therapy, do you all feel that every visit should be a joint breast surgeon and medical oncology visit, either simultaneously or at different points early on? Or do you feel like the breast surgeon should be making those decisions?
In my case, because I'm not in the same office, there are people who have those joint things. We're across the street from each other and we're readily available. But sometimes, for instance, there are some cancers, say DCIS gets a mastectomy that's ER negative or ER positive or ER negative lumpectomy. I'm happy to follow them, but it's still important to speak that up with the medical oncologist and offer the patient and the medical oncologist, is there any value you want to connect with each other. And if they say no, then I'm happy to follow them. And so I don't think that every visit has to be joint, but I do think you need to be a part of a good team and a team that you trust.
Yeah, I think that's a good point. The telephone is your friend on this. And if you guys are speaking the same language, hey, this is what I'm seeing. Do you have any trials for this? Is there anything that we should do differently? She may not meet the exact criteria, or maybe there's something new that a new trial is open that I'm unaware of, and it gives me an opportunity to learn about that. So typically we'll run that past them, even if it's just a quick phone call and say, how do you want me to proceed? I'll just go on to surgery. Sounds good. We'll see him afterward. Okay. But now you've got that. You can put that in your note as well, too. And it's easier on the patient than having to wait in two people's waiting rooms on the same day. Most of us don't have a true multidisciplinary clinic where I walk out and the medical oncologist walks in. I think that's great if you can have it, but I don't think that's real world for most of us.
I also think there's a lot of information overload. I mean, it's just like us sitting in a 3-hour lecture, and that's a long period to be learning such a wealth of information that having that break kind of gives time to digest and come back. We all know we've seen patients and they heard the first 3 words and we need to go through that again. And so I think there's also value with split visits as well. It's different for different patients. Some people can really handle that, and other people, the split visit's really helpful.
Yeah. Well, this has really been a great episode, guys. I think we were able to cover reasons why breast surgeons have been and should continue to be integral parts of the decision-making regarding neoadjuvant treatment, and comfortably advocate for ourselves to continue to be in that role, understanding that it's a complex decision and really multidisciplinary care is essential. But believe it or not, we are just about out of time. Before we close, let's go around and have each of you share one thing you'll take away from this episode.
I really like the idea of maybe making this a midpoint visit. I usually do it towards the end and I make it pretty vague, but maybe I discuss with the medical oncologist, and if it's 6 cycles, I want to see him after the 3rd cycle, or if it's 4 cycles, I want to see him after the 2nd cycle, and be more proactive with that communication.
What about you, Michael?
I think we need to know as surgeons that we control this in most cases as to whether or not a patient's going to get neoadjuvant therapy. So it's incumbent on the surgeon to know what's out there, what the best course of treatment is, and be thinking about neoadjuvant. Even when you see every patient, doesn't mean everybody has to have it, but when you see them, think, should I be considering a neoadjuvant treatment for this patient?
And I love what you said earlier about knowing the trials at your institution. What about you, Ellie?
I think this episode just reminded me, like Susie mentioned a little bit before, of how lucky we are to be in this field that is ever evolving and changing day by day. And hopefully we will see a world where breast surgery isn't needed in some situations. And so it always lights my fire a little bit when we kind of remind ourselves of being part of such a cool field and knowledge base of things that are evolving. This is definitely an evolving field. And like Michael said, it's our job to stay on top of it. It's our job to know who needs neoadjuvant and who doesn't. And I do see that in community practicing physicians who maybe aren't on these tumor boards or CMEs, that they might miss this stuff. So it's really incumbent upon them, and it's starting to appear on the board certifications and stuff like that, but it's a ways off. You know, it wasn't on there yet for general surgeons. So I think it is definitely important, if you're practicing breast surgery, you stay up on this stuff, and so you can do the best for your patients.
Those were amazing take-home points. Thank you, guys. To our listeners throughout the breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
Sitcha,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.